is collagen. That's scar tissue. Okay. So this was an area that had probably a heart attack in the past, but has since then scarred and healed. So that's scar tissue. So this is what happened in a myocardial infarction. And in the exams, you need to estimate the date of the myocardial infarction based on the population of the cells. Is it acute within a certain amount of hours? Is it already a chronic? This one is already a chronic one that's healed. Because it takes a long time for it to heal like this. Okay? So, myocardial infarction. Right? What else do we have? Alright, we have this slide. Okay. So we have this big ovoid structure. Right? See this big ovoid structure, and in the center of this ovoid structure is this pink amorphous-like debris. What do you call the entire structure? The whole round structure? It's called a granuloma. Granuloma. Called a granuloma. And then what do you call the pink stuff in the center? And if you look at the pink stuff in higher power, it's just pink amorphous debris. It's a type of necrosis. What type of necrosis is this that you see in a granuloma? Caseous necrosis. So when you see the cheese-like stuff, the white friable material, that's this pink amorphous stuff that's coming out. It's caseous necrosis. So what about, what conditions do you see caseous necrosis?
Tuberculosis.
Tuberculosis is the number one. Okay. But it's also seen in other conditions, like fungal diseases. Now, sometimes you can see this very large cell in the center. This is not the ideal one, though, but the old slide has the ideal one. Where did it go? Most of these cells that are surrounding the granuloma, why does it not match? What is this giant cell called? Notice the arrangement of the nuclei is kind of somewhat like a U or letter C. Kind of, sort of, not perfect. What is that multinucleated giant cell that has that C shape or horseshoe shape arrangement of the nucleus? That is the Langhans giant cell. Correct. Not to be confused with Langhans. Okay? Not to be, those are different cells. So what those cells are, that giant cell that you see, they're actually monocytes that fuse together to form this one giant cell in order to combat whatever foreign particles or debris is there. And then all of these surrounding cells, most of them are actually histiocytes, or histiocytes are basically macrophages. But the thing about these macrophages, they're more plump than normal, meaning they're bigger. So they kind of look like epithelial cells. That's why we call them epithelioid histiocytes. That's the one forming the wall of the granuloma. Most of these cells that you see. As well as there are some lymphocytes, like the darker circles. Yeah, these dark circle ones are lymphocytes. The other cells are histiocytes. They're larger, kind of look like epithelial cells. Okay? So this is caseous necrosis. This is a granuloma. Okay? And then you have the giant cell. Alright, let's look at another one. So, if I told you that this is a mass on maybe the upper back or shoulder, what would your diagnosis be?
Lipoma.
Lipoma. Okay. Is this benign or malignant?
Benign.
It's benign. Now, let me ask you, is this a well-differentiated, poorly differentiated, moderately differentiated, or just completely anaplastic? It's well different. What do you mean when we say something is well differentiated? It looks exactly like normal tissue. In fact, you wouldn't even say this is a tumor if I told you. If I told you this is just a subcutaneous, you would probably believe me, right? Because it looks identical. It's well differentiated. Generally, as a rule, well differentiated tumors are benign. Generally, but there's exceptions. Huh? There's almost always an exception, except for cases with anaplasia, metastasis. Those are definitive for malignancy. Okay. All right. So, and there are also special variants of lipoma too. which type of lipoma is actually painful? Do you remember? Or not yet? No? It's okay if you don't yet, not yet know. Because sometimes they ask this. Most lipomas are non-tender, but there is a variant of lipoma which is painful. Because most tumors or masses are painless. But the variant of lipoma that's painful is called an angiolipoma. It's a lipoma that has a lot of capillaries. And since capillaries have a lot of nerves and they could bleed, they tend to be painful sometimes. So it's one of your painful skin tumors, a lipoma. Angiolipoma to be specific. There's another variant of lipoma where there's fat and collagen. That's called a fibrolipoma. But in this case, this is just your regular old generic lipoma. Right. Next. Oh, there's another lipoma. So, I took 2 slides for that. That one was a little bit better state. Oh yeah, I don't like this slide because the staining is really bad. But I will try to show it to you anyway. So this tumor is actually a tumor of the parotid gland, or the parotid gland, depending on your pronunciation. If you remember, it's one of your major salivary glands. And what's the predominant type of gland in that? Serous or mucus? Serous. But here you don't see any normal serous glands. What you see in this tumor, this is a special type of tumor because when we say carcinoma, what do we mean carcinoma? Where did the tumor originating from? It's coming from the epithelial cells. So carcinoma are epithelial cells. What about sarcomas? Sarcomas are from the mesenchyme, the connective tissue. Lipoma, osteos, sarcoma. Those are all sarcomas. Or actually liposarcomas, the middle portion. So this one is unique because it's not just the epithelium, but it's also the stroma. So it's called a mixed tumor. So this is a benign mixed tumor, or also called as a pleomorphic adenoma. And what you see is there's a proliferation of both the mesenchyme, and sometimes the mesenchyme looks like it's forming cartilage. It could form cartilage, it could form bone, it could be like mucus-like, mucoid. And then for the epithelial elements here, they're the little solid nest of cells. They're forming sometimes glands, nests, solid structures. So in this one, it's relatively unique. This is a mix of, here's the epithelial component. These linear cells, okay, in nest. That's the epithelial, and then we see the stromal component. That's a benign mixed tumor, pleomorphic adenoma. Most commonly seen in the parotid gland, okay? And it's the most common tumor that you see there. Okay? Although the staining here is just really bad because everything is quite pink. There's another cell that you can see here, but it's hard to see. It's the myoepithelial cell. Remember what a myoepithelial cell is? It's the cell that usually surrounds the glands and causes it to contract. Yeah. But they're hard to see here because it's kind of obscured with all of the epithelial and the stromal elements. So that's pleomorphic adenoma. I know the slide is a little bit jumbled. What's the key takeaway is to identify that it's both epithelium and stroma, hence the mixed origin of this tumor. Pleomorphic adenoma. Alright, now we've got this one. Here it is. This one, do you know what organ this used to be, I should say? Because it's all dead now. What do you think this organ used to be when it was still not undergoing what happened to it? Let's take a look at it. What do you see? You see somewhat tubular structures. Okay? Tubular structures. And these tubular structures So these tubular structures are actually full of red blood cells and shadowy outlines of cells that used to be there. You see, they kind of look like ghost cells. Like you see a vague cell membrane. surrounding some of these cells. So it kind of looks like a ghost because the cell died there. So what type of cell or organ has a lot of tubules and that are packed full of these cells? And then even some of the cells in the center are more thin and elongated and have flagella. So I have to give you a giveaway. So yeah, this is the testis. So what structure was this used to be? That used to be your seminiferous tubule. So this condition, what condition do you think happened in your patient? Is it cancer?
No.
Do you think it's cancer? No, this is cancer. This is testicular torsion. So the testis twisted. And when it twists, remember, what is the components of your spermatic cord? You have the vas deferens, you have the testicular artery, you have the, what are the veins? Piniform plexus and the nerve. Which of those, okay, from your spermatic cord, two of those are blood vessels, the testicular artery and the vein. Which one is prone to collapse easier? Or which one will collapse first if there's tension, stress? The vein or the artery? Vein, because arteries have a thicker wall. They're more durable. So in testicular torsion, the veins will, as the testis is twisting, so is the spermatic cord. And as the spermatic cord is twisting, this collapses the veins. So what happens is there's more blood flow going towards the testis than there is exiting the testis. So meaning, increased blood flow, it will make the blood leak out of the blood vessels due to hydrostatic pressure. So that's what happened in this case. And what's the most common testicular deformity seen in testicular torsion? That's another buzz question or pathology pearl. It's called the, it's okay if you don't know, bell clasper deformity. Okay, it's the bell clasper deformity. Then also try to understand the clinical history and the physical exam of testicular torsion. Okay? And so what type of necrosis do you see here?
Normal.
What type of necrosis? What are your different types of necrosis?
Coagulative.
Yeah, so this is actually coagulative. Why is it called coagulative? Because it maintains the architecture. You can still see the seminiferous tubules. So it has the architecture. Okay? So that's why it's called coagulative necrosis.
Okay.
Right, next. Alright, so this is something pretty interesting. This specimen came from pleural fluid. So they took the pleural fluid and they spun it in a centrifuge. And then they collected the sediments and put it into what is called a cell block. Okay, so if you're medtechs, you're familiar with that. So, but for just med students, it's a cell block. They just basically got the fluids and the sediments. And now we're looking at the sediments under the microscope. Okay? Now, what we see now, what's important is to look at the cells. Do you think these cells are benign or are they malignant? Okay, so we have a guess for a malignant. So when we look at the cells, let's take a look at it. We see a cluster here. In fact, it's kind of forming like a gland. Doesn't it resemble like a gland?
Yeah.
But look at the nucleus. Are they uniform? No. So what's the term if they have variation in size? Pleomorphism. Okay, or pleomorphic if you're using adjective. So it's very pleomorphic. And then also look at the color. It's very dark. What's the term if it's dark? Hyperchromatic. Hyperchromatia. Okay? So these are features of a tibia. Okay? So they favor a malignant diagnosis. And this probably is malignant. And that also has the arrangement of the nucleus is it's kind of sticking out. It's like popping out of the cell. So as my consultant said, it's a popping out nucleus. It wants to escape the cell. So you see this in a malignant pleural effusion. Okay? Most likely this came from an adenocarcinoma because it's vaguely forming glands. So when we say gland, it's adeno. And then it's cancer carcinoma, adenocarcinoma. If it's benign, adenoma. Okay? So this is probably from a Metastatic adenocarcinoma. That's a pleural fluid. Alright, next organ. You might have recognized this organ. So we see there is a prominent fibromuscular stroma. It's not just collagen, it's also muscle tissue. And we see these glands, although these glands are dilated because the cells are multiplying. What do you call it when there's an increase in number of cells? Hyperplasia. So these cells are growing so much that the gland themselves are actually getting bigger because they're multiplying. The cells are growing and therefore the gland will be also growing as well. Do you know what organ this is? This is actually the prostate. The prostate. You've actually seen this in the lab because some of our slides in histo have this condition. So what's your diagnosis? Benign prostatic hyperplasia. Because in the normal glands, remember they're supposed to be small and undulating. They're undulating. They're no longer undulating because they multiplied and they're stretched out. So this is BPH. And the problem with this, because these glands are growing and pushing the tissue to the side, it also compresses the prostatic urethra, therefore causing urinary obstruction. So now that you know the clinical, the pathophys of this, you could now explain the clinical manifestations. Meaning, with that, because it's blocking the prostatic urethra, they have difficulty in urinating. So maybe the strength of the urine is very weak. It's what we call dripping, like little drops. Or sometimes it's hard to initiate it because it's blocked. And then maybe after they urinate, 10 minutes again, they'll urinate again because they weren't able to fully empty the urinary bladder because of the blockage. Okay? And then another symptom at night, they'll always wake up at night, like 10 o'clock or midnight, just to urinate. This is very common in elderly individuals. BPH is very common, especially when you get to 70 and 80 years old. So, BPH, benign prostatic hyperplasia. Now, do you remember the zones of the prostate? And do you remember which zone I asked you is most prone to BPH versus which zone is most prone to prostate cancer? Do you remember all those zones? No, it's okay. But you should know that now that you're second year.
Tell us that. Remind.
All those zones. Alright. Oh, this one. So, I will show you something. This is, in the exam, they might ask you this, but I don't think they'll ask you anymore because this is a tumor which is no longer seen in Robbins. Robbins took out the name of this tumor. Originally, this is called fibrosarcoma. It's a malignant tumor of fibroblasts, fibrosarcoma. But the problem with fibrosarcoma is a wastebasket diagnosis. Meaning, if you see this pattern, and the pattern is called a herringbone pattern. Okay, a herring is a fish bone. It's a type of fish. So let's see if we can find a very ideal textbook picture of a herringbone pattern. Yeah, sort of, but it's not. Here. Here. So herringbone pattern. It's like a V shape. It looks like the backbone of a fish. That looks like V shape like that. That's a herringbone pattern. It's hard to visualize here. Think of it as like the backbone of a fish. Okay? That's the herringbone pattern. In the past, this is always associated with fibrosarcoma. But that's a wastebasket diagnosis because technically when they did cytogenetic studies and they did immunohistochemical staining, there are several tumors that can look like this. Synovial sarcoma, okay, malignant peripheral nerve sheath tumors, dermatofibroma sarcoma, protuberance. There's a lot. So this is a wastebasket diagnosis. So you might not see this in the latest edition of Robbins. They moved it out a long time ago. But just for the old pathologists, when you see herringbone and you see these collagen and fibroblasts, fibrosarcoma. I probably won't use this in the lab, but I need to show you because it's an old classic pattern. There are a lot of patterns in histology that you will have to learn. There's also story form patterns. Story form is like a pinwheel, the one where you blow it, the wheels spin around. That's a story form pattern. There's a lot. There's vesicular patterns, ball patterns, ball. You'll learn that as we go through histology. But this classic V shape is the herringbone pattern of fibrosarcoma. Although nowadays it's not really fibro, it's a lot of tumors. Okay. This one, it's a little complicated, but I just want you to differentiate the normal compared to the abnormal. Okay? So let's somewhat look at the normal first. Not exactly normal. Do you know what organ this is? What's that in the middle? A central canal, vein, artery, nerve, aversion canal. Central vein. This is the central vein here. What are these cells? Yeah. Well, the structure is the hepatic cords. The cells are the hepatocytes. Yeah. That's right. So this is, of course, what organ? Liver. So this is somewhat normal. Actually, it's not normal because there are a few things I want to point out. So this is the liver. Okay, so good job. And you remember your histo. Let's look a little bit into the liver. There's a big better area. Okay, so first off, we see some inflammation. So we see a lot of little mononuclear cells. What is the mononuclear cells are the cells that you usually see in chronic infections. As opposed to acute infection, what's usually the predominant cell in acute infection? Neutrophils. Don't worry, you'll learn about that tomorrow. So we see some chronic inflammation. And then, oh, there's more here. There's a lot of inflammation. All these little small cells. They're mononuclear lymphocytes. Okay? And then we see in, where's that one area? We'll find it again. Anyways, let's not bother ourselves with that. What's important is to differentiate this type of tissue, which is the normal, well, moderately normal, compared to this tissue here. Are they forming nice hepatic cords?
No.
No. They're actually, this is actually not a tumor of hepatocytes. To be specific, these cells that you see, they're not hepatocytes. They're actually the cells lining your biliary tree. So your bile ductules, and they also are the same cells lining your common bile duct, and all of your hepatic biliary tree. Those cells, what we said, I call them simple columnar or simple cuboidal cells, they actually have a name. They're called cholangiocytes. So this is a tumor of those cholangiocytes. So this is a cholangiocarcinoma. So a tumor of the bile duct cells. So take a look, I just want you to look at the nucleus. You see the pleomorphism. You see the hyperchromatia. It's very invasive. It's not just like forming a distinct mass. It's just invading everywhere. And then the background is kind of like somewhat collagenized and edematous and some inflammation. But for now, just be able to recognize, compare this one to the normal benign cells here. Okay? So look for pleomorphism, hyperchromatia, loss of polarity, etc. So this is cholangiocarcinoma. Next. Okay. Do you know what organ this is? Yeah, good job. It is the endometrium. Here's the myometrium, the muscles. And here's the glands. But look at the glands. The glands are not really arranged in a very beautiful pattern. They're not like together, going in the same direction. They seem to be very haphazardly arranged, like someone just put them in random directions. And then these glands are very close to each other. You may think it's secretory endometrium, because we do see a little bit of a sawtooth pattern. And you are correct that it is a secretory base, but it's the way the glands are arranged is too disorganized. It's because they're growing out of proportion. Okay, they're multiplying. This is what we call as endometrial hyperplasia. Okay. Now, there are two categories of endometrial hyperplasia. You have to call it endometrial plasia without a tibia or atypical endometrial hyperplasia. In this case, let's try to look for a tibia. Let's look at the cells. So we will practice looking for a tibia. Do you think the cells are forming like stratified structures or still single? Are they relatively uniform? Relatively, right? Relatively. Are they really, really dark looking? Not so much. Maybe a few, but not really. Within normal limits. So this is without a tibia. Endometrial hyperplasia without a tibia. You need to distinguish a tibia from atypical endometrial hyperplasia from endometrial hyperplasia with a tibia. Because if there's a tibia, that is an increased risk for malignancy. That's the importance of finding a tibia. But here, endometrial hyperplasia without a tibia. Okay? Just the glands are disordered. Some of them are even cystically dilated. That one is enlarged. Very nice. Next one. What is this one? Oh, this is another pleomorphic adenoma. Here you see it looks like kind of like bone a little bit, and the epithelial element. But again, this is not a good slide. I'll show you the other one. Let's skip that. Oh yeah, this one. I think it's upside down. Okay, so let me tell you where this specimen came from before you give the diagnosis. So this specimen is from an ovary. So what's the lining epithelium that you see? Although I know the staining is quite bad. It's here, the lining epithelium, stratified squamous. Is that normal for an ovary? No. What's this structure in the center, the circular thing? And what's this? So first, what's this structure? Oh, you guys are funny. That's a hair follicle. Do you see hair follicle in a normal ovary? No. What are these? Sebaceous glands. We see a lot of interesting things that do not belong in an ovary. We even see, what are these? Apocrine sweat glands. You actually didn't see apocrine, you saw eccrine sweat glands. And that's where you're in the one section where I showed you the apocrine sweat glands in your practical exam. And then we see smooth muscle, and we see adipose tissue. What's your diagnosis? Teratoma, or mature cystic teratoma, or dermoid cyst. Okay? This is a very common neoplasia that you see in usually reproductive age women. Is this benign? Does it really look anaplastic and pleomorphic? It looks like normal skin adnexal structures. So this is a benign tumor. However, in the male, is this benign? No, it's actually malignant in the men. In males, this is malignant. In females, it's actually benign. Now, there's another counterpart to this called the immature teratoma. In the immature teratoma, your tissues are not like this. They're not mature. So instead, you'll see immature, undifferentiated cells. They look like very small, round, and blue cells. That's called an immature teratoma. That's more common in pre-pubertal females. And that one has a risk for malignancy. Okay? There's also a very specialized monodermal type of dermoid cyst, which is only composed of one type of tissues. What do you call a teratoma that's composed completely of thyroid tissue? And it can actually cause hyperthyroidism. Struma? about it. Okay? So yeah, that could be a cause of ectopic hyperthyroidism if this teratoma is only thyroid tissue. Okay? Alright, so let's look at now my new slides. And I think I've showed some of this to you yesterday. So we'll go over them. This is another endometrium. This is a better one than the old one. Look at these glands. Some of them are very cystically dilated, right? And then are they in a nice, beautiful arrangement, or are they just kind of blah? They're just a little bit everywhere, right? In no particular direction. And there's more. They're like very close together, different directions. This is your diagnosis is endometrial hyperplasia. Now I have this one. Look at this one. This is something also characteristic of endometrial hyperplasia. Look at this. You have a gland within a gland. The glands are multiplying so much that they're starting to just grow within the lumen themselves. Hyperplasia. That's a gland within gland formation. So endometrial hyperplasia. Gland within gland. And this is without the tibia. Without the tibia. Endometrial hyperplasia without tibia. Then we have another feature we can sometimes see. We see a gland here, but then there's an outpouching. Like they're still multiplying so much that they're going out of the gland. That's stromal outpouching. Again, another feature of endometrial hyperplasia. So this is a more better slide of the classic features of endometrial hyperplasia without the tibia. Okay? So gland within gland, disordered increased number of gland to stromal ratio, stromal outpouching. Okay. Very nice. Next. It is. Okay, so let's start off with the normal. What is this organ? Yeah, colon, good. This is the normal colon. These are cross sections of your crypts of librocum, little flower. But we have a problem. We start to go here, and now we see there's like a little stalk that's coming out. It's a polyp. It's actually a polyp. And then now look at the glands of these polyps. Let's take a look at them in high power. Now we get to see that the cells are not exactly simple columni. They're starting to become stratified. Okay, a little bit darker than normal. So they're having some dysplastic features. Okay, so this, but it's still not through the basement membrane. It's not invasive cancer. So this is what we call a tubular adenoma because they're forming tube-like structures. But they have evidence of dysplasia. But it's not invading into the surrounding lamina propria. So tubular adenoma, which carries a slight increased risk for colon cancer. So that's why you have to remove these polyps. Let's look at this one. Ooh, look at this one. Yeah, look at this one. Really, they're really stratified. And they're starting to become a little bit elongated instead of the nice oval appearance. That's what we call the pencillate. It's like a pencil. So those are signs of dysplasia because the normal nucleus is supposed to be round. Next. What's this one? Oh. I'll show this to you later. But do you know what organ this is? Have you forgotten? There's no submucosa. I'll show this to you. Alright. Oh, yeah. Okay, now look at these glands. Do you consider this as endometrial hyperplasia? Do you think it's cancer? Or is it just normal? What's your guess? How many of you say normal? Normal? see a few. Good, good. Endometrial hyperplasia. Anyone think endometrial hyperplasia? So then everyone else says it's malignant. Okay. Understandable. So you think it's all malignant, right? This is normal proliferative endometrium. The glands are tubular. There's no increase in glands. Okay? They're even all relatively facing the same direction. So this is a proliferative endometrium. But what I want to show you, this is the myometrium, normal myometrium here. But if we go to the side, there's something a little bit distorting the myometrium. You have this nodule. See this nodule on the right? So in the myometrium, we see this round ovoid tumor, and it's somewhat distorting the endometrium because it's pushing up against it. What do you think this tumor is? Yes, this is a myoma. And a myoma is composed of what type of cells? Fibroblasts? No, that would be fibroma. They resemble the same cells that you see in the myometrium here. So these are smooth muscle cells. So a myoma is a benign tumor of smooth muscle. It has what we call the classic whorled appearance, but the whorled appearance is best seen grossly. You can vaguely see it that it's going around. It's like swirling here, forming like a little cyclone. That's the whorled appearance. Better seen grossly. You can see it there. We have the gross specimen at the back. You can look at it. Okay? So this is a myoma. This is just, it's a little bit distorted because of the myoma. But it's generally overall a proliferative. A few cystic. Don't mind the cystic because it's most likely due to this myoma making it a little distorted. But overall, this is a very good slide to study proliferative endometrium. And there is the myoma. Next. Ooh. Okay. So here, I'll show you what's left of the normal tissue first. This is all that's left of the normal tissue. What organ is this? Thyroid. Although there's a lot of inflammation.
That's called like.
You see the small cells surrounding the thyrocytes, these little dots, those are just lymphocytes. So there's a lot of lymphocytes. But the problem isn't the lymphocytes. The problem goes here in this area. Okay? These are not lymphoid follicles, right? They're not. And they are actually forming. This is another architectural pattern. You saw earlier the herringbone pattern. This is what we call the papillary architecture. Papillary meaning they're forming like multiple branches, okay? Like little branches. And in the center of the branch is a fibrovascular core. And then what's happening is the thyrocytes are now malignant. Okay? They're not forming follicles, they're forming papillary structures. And if we look at the nucleus, they have a very characteristic appearance. The nucleus is what we call optically clear, or ground glass, or the other term is the orphan Anne nucleus. Orphan Anne is actually from a very old comic strip. She was an orphan, and her name was Anne. So hence Orphan Anne. That Orphan Anne. And that person, when they drew Orphan Anne, she had these big, wide, white eyes and a very small little pupil like this. That's the Orphan Anne. This is known as papillary thyroid carcinoma. It is the most common type of thyroid cancer that you encounter. But let me tell you, the presence of, you might not always see papillary structures in a papillary thyroid carcinoma. What's more important are the nuclear features, the papillary-like nuclear features, which is the Orphan Anne, and other features when you look at them. Okay? But this tumor is an example of a moderately differentiated carcinoma. It's not well because it doesn't look like thyroid, right? But it's still forming recognizable structures. In this case, it's forming a papillary structure. So it's still a moderately differentiated type of carcinoma. That's papillary thyroid cancer. say about this endometrium? Is it benign or malignant? Are they going in really random directions, or are they more or less going in the same direction? Same direction. But now we see the very classic sawtooth arrangement. And the glands are actually relatively uniform. They're all going this way. Do we see gland within gland? No. We don't really see outpouching. Okay? This is secretory phase. This is now your real secretory phase. I also got this after we finished the reproductive system, so I didn't show it to you in this one. Because it's one of my newer slides. But again, the feature is another myoma here. See, it's forming a little. It's here on the left. This is a small myoma compared to the normal myometrium here. Here it is. Myoma. Sometimes these myomas can get very big. So I had one time a giant myoma that was so big they put it in a trash can. And then these myomas, they're very hard to cut when they're fixed in formalin. So even if I have a giant knife and I'm beating it, it's not gonna get really hard to cut. You can hurt someone if you throw it at someone because it's really hard. These myomas. Yeah. That's just a myoma, but I just wanted to show you the secretory endometrium. Don't call it cancer. I'll show you the cancer later on when we go to reproductive. Ooh, yeah, I love this one. This is a very classic textbook picture. All right, let's go to the normal. Here's the normal tissue. What's the organ? Yeah, breast. So you see the acini and you see the ducts.
Yeah.
That's the normal epithelium. Normal. Is it lactating? Non-lactating. Non-lactating. So that's normal. Unfortunately, she had a ill-defined mass, which is here.
Oh.
This is the diagnosis of this. It's a type of breast cancer. Okay. Specifically, well, we'll learn it more in detail. This is called a lobular carcinoma. It's the second most common type of carcinoma. The other one is actually ductal carcinoma, or what is known as just, nowadays we don't use ductal carcinoma, it's an old term. So we call it mammary carcinoma of no specific type. Because technically there are several types of breast cancers, and lobular is one of the subtypes. But the most common is of no specific type. But anyways, in lobular carcinoma, the acini and the ducts, they form these cohesive structures that are kind of arranged in a line. See? One by one. That's called the Indian filing. I don't know why it's called Indian filing. So yeah, that's Indian filing. The cells are discohesive and they're forming linear strands. So that's a lobular carcinoma. Do you remember when we practiced the Nottingham grade? So we gave a score. So what would be the tubule formation in this one? Is it forming tubular structures? No. So what score would you give in the tubular formation? It would be a score of 3. 3. Because if it's mostly tubes, it's 1. Moderate the amount of tubes, 2. And then no tubes, 3. So this is the tubular grade 3. Then what are the other features that we use in the Nottingham grading system? Mitosis. Mitosis, if there's a lot, moderate or minimal amount. Okay, 1, 2, 3. What's the last one? Tubular pleomorphism. Probably not so prominent here. So you probably give it a 1 or a 2 here. So that's how we do the Nottingham grading scale. So this is lobular carcinoma of the breast. Okay. And we have also here, this is something interesting. This is the in situ counterpart. This is the non-malignant portion here, where what they're doing is they're filling and dilating the ducts with the tumor cells. But these tumor cells haven't yet invaded the stroma. Unfortunately, cells here are already invaded. But this one is the in situ, this is the invasive component. So this is a nice slide to show you what it is when it's still in situ versus what it looks like when it's already invading the stroma. Okay? So that's lobular carcinoma of the breast. Alright. So what is this organ here? I know it's sideways because I can't rotate it. Skin. Keratinized. stratified squamous. Correct. But we see something here. What happened to the skin here? We see a lot of inflammation again. But we see these cells that are going down into the dermis. It's already invading the dermis. And if we look at these cells, we even see a very unique structure here. So you do need to know that structure. That structure is called a keratin pearl. Because what cells produce keratin? Squamous cells. So this is a squamous cell carcinoma. Because it's a tumor of malignant squamous cells. So squamous cell carcinoma. If you see keratin pearls, that tells you that that tumor came from squamous cells. Because the treatment of squamous carcinoma is different from that of adenocarcinoma. So you need to know the difference. Another feature is, let's see if we can see it. We'll go to high power. Yes. Do you see these little spines? Do you remember stratum spinosum? That's where desmosomes. These are called intercellular bridging or intercellular bridges. That's also characteristic of squamous cells. So sometimes squamous cells are difficult to appreciate, or you might not be able to tell a squamous cell carcinoma from a very solid type of adenocarcinoma. But if you see intercellular bridging, if you see keratin pearl formation, that gives you a hint that you're looking at a squamous cell carcinoma versus a different type of carcinoma like adenocarcinoma, which is glands. Okay? Squamous cell carcinoma. And this is the skin. So what's the number one risk factor for squamous cell carcinoma? UV radiation. So those who are exposed to UV light, those who are also fair in skin, the pale white people. What are these here at the center? Again, I'm showing you for the how many time. Apocrine sweat glands. That's your apocrine sweat glands. Okay. Next year, eccrine. This is the eccrine sweat glands and ducts. Okay. So, yeah. This is squamous. Oh, another keratin pearl. There's even some apoptosis, I think. That's apoptosis. Anyway. Here. So these cells that are pink, and the nucleus is a little bit, these are cells that are undergoing apoptosis. They're shrinking, you're dying. So, apoptosis. Alright, so squamous cell carcinoma of the skin. Oh, yeah, this is the bad one. Let's find it. Okay. I know you won't be able to kind of tell what this organ is. So let me explain what you're seeing, or what this organ used to be. This organ was originally a kidney. What happened to the kidney tubules? Most of the kidney tubules died. The few kidney tubules that are remaining are here. And they're undergoing what we call as thyroidization of the kidney tubules. Because it looks like a thyroid. It looks like, but it doesn't function as a thyroid. It doesn't secrete thyroid hormone. So it looks like thyroid hormones. So kidney tubules, when they die like this, they tend to undergo this thyroidization effect. Because they're no longer able to absorb and secrete material. So all the things just stay there in the middle. But look at the surrounding tissues. What we see is a lot of inflammation. Okay? Do you think this is cancer? Yeah, it's not cancer. We don't see really any malignant looking cells. Instead, we see a lot of cancer. We see a lot of inflammation. Like really, and we see a lot of fibrosis, which is scarring. Scarring itself doesn't necessarily mean it's malignancy. Okay? And we do sometimes see. What is that people? We do, well, maybe it's not here. Oh. There's, you see heavy inflammation. Maybe it's the other side. Oh yeah, here. We see some multi elongated giant cells. These cells are responding to the initiating event. So what's causing this? So you have to know the history of this patient. This patient had a giant kidney stone. Okay? So that was nephrolithiasis. It was causing obstruction. So his kidney underwent atrophy. What's atrophy? Cell shrinkage. Yeah. They shrank and then eventually they died, leaving scar tissue. And then these are just monocytes that are combined together to just clean up the remaining dead cells and produce scar tissues. Okay? So that was just. So the diagnosis of this is technically chronic nephrolithiasis. Chronic nephrolithiasis causing chronic pyelonephritis. Okay, so you don't need to really know that, but I just wanted to show you some. And look, we have also here, we have some calcifications, a little bit of chunks of pieces of the stone. So that's calcification. But this is different from your dystrophic and metastatic. It's different because this is due to a kidney stone. But there are two types of calcification, dystrophic and metastatic. Which of those types of calcification occurs when there's areas of necrosis? Dystrophic or metastatic? Dystrophic. Which one has normal calcium levels?
The other one.
Dystrophic, metastatic? Normal calcium levels? No, still dystrophic. Still dystrophic. So you need to know those types.
You can remove. Oh, this was painful.
Next.
That's okay. Thank you.
So, what organ is this?
How did you even recall this?
Thyroid gland. Thyroid gland. Unfortunately,
It's little of staples. You read the.
we have this
These are
mass.
reusable, right? You just kind of like yank them out.
Benign malignant. It's malignant. Well differentiated, poorly differentiated, moderately differentiated, anaplastic.
Moderate. I don't know.
They're not forming any structures. We don't see glands, we don't see papillae, we don't see herringbones. Yeah, this is anaplastic thyroid carcinoma. It's the rarest of the types of thyroid carcinoma, but it is the most deadliest. This has a high mortality rate, almost reaching the 90s and 100%. Very high mortality rate. You will not be able to look at the look at the size of that cell here in the middle. See that cell? Even has a very weird nucleolus that's really elongated. Yeah. There's really marked pleomorphism. We have this giant nucleus and we have a smaller nucleus, a very prominent nucleolus. Yeah, that's pretty ugly. And you can't even tell what this used to be. So this is one of the hallmarks of malignancy, anaplasia. The other hallmarks being invasion and metastasis.
But the max size is only like this much.
Next.
A bigger size.
We have another.
The refill. Of course, either one.
Okay, so we have here benign malignant. So yeah, this is just a normal pap smear. This is a liquid base or the SurePath. Very nice, uniform. These are mostly your squamous cells. If you want to be specific, they're the intermediate cells. Okay. Not yet superficial, because this one's the superficial. This one's the intermediate. Intermediate is superficial here. It has a smaller nucleus. You don't need to know that. So yeah. Oh, we see also here lactobacillus. Not protectus, that's a different species. That's the one in your digestive tract. Lactobacillus protectus. So this is just benign, beneficial bacteria. And we see a few inflammatory cells, more lactobacillus. Not to be confused with tuberculosis, which is also a bacillus. Okay. Okay, next slide. Got a lot of slides to look at. I think this is the same. Another duplicate. Yeah. So here's the colon. And here's the dysplasia. This one's better because now you can see it's more clean. The really elongated pencilate cells. They're really elongated. So that's another tubular adenoma. Tubular adenoma. Sometimes instead of forming tubular, they can also form villus structure. That would be called a villus adenoma. And then sometimes you get a mix, so it would be called a tubulovillus adenoma. Got a lot of, oh, this is an interesting specimen. Let's find the normal. It's somewhere in the corner, if I remember. Find the normal. Find the normal. Ah, yes. Here it is. It's upside down. So that means I have to rotate it and go to the other corner. Other corner. Okay, so what organ do you think this is? Close, because it looks like the colon. This is actually the anus. This is the anus, because the proximal portion of the anus is the same as the colon. That they have trips of liver, but then it becomes stratified squamous as it goes towards the skin, right? But what happened at the skin? This is too much skin. Alright? This is way too much. This is too much. So grossly, this looked like a cauliflower. Okay? It's like a little cauliflower-like mass. And so we see a lot of these squamous cells that are proliferating. And we see, interesting, these relatively large cells here that have a somewhat of a halo and a little bit irregular nucleus. That cell is called a koilocyte. Koilocyte. So that's your buzzword. What do you think this disease is? Occurs in the anus. Koilocytes. Due to a virus. It is due to HPV. Due to specifically low grade, because the high grade is the one that will give you squamous. So this is due to low grade HPV. Keep going. That's the etiology. Now it's the diagnosis. So we know that koilocytes, we see HPV. So this is you can use the medical term or the layman's term. Genital warts, layman's term. Or, this could be specific, condyloma achinoma. So that's a sexually transmitted disease. This is near the anus. So you can guess how he got this one. Okay. So that is a sign of HPV, the koilocytes. Genital warts. Oh, I love this one. This is such a classic textbook picture. Unfortunately, this tissue has there's no normal tissue in here. So I'll just tell you that this is from the breast. Okay. It's forming a well-circumscribed mass. Here's the border of the mass. It's very circumscribed. Smooth borders all throughout. It's just going around. Very nice, smooth borders. And then we see this. Okay. Do you think this is benign or malignant? It's actually benign. Yeah, relatively. Smoother borders generally favor benign neoplasm because malignant, they infiltrate irregularly. This one's benign. So what's actually happened here? This is a tumor not of the epithelium, but of the stroma, of the fibroblasts surrounding the terminal acini and ducts. So the stroma is proliferating. And because it's proliferating, it's compressing your mammary ducts and your mammary acini to form this flattened-like appearance. So all of your breast glands have been squished because of the proliferating stroma. So this is a benign neoplasm, and it's called fibroadenoma. Now, what does a fibroadenoma present clinically? Clinically, it's usually in a young, reproductive age woman, right? Many of our females right now, so in your age group, and they present as a firm, rubbery, mobile mass. Okay? Firm, rubbery, mobile mass. Okay? And we see this particular pattern. Fibroadenoma. There is another tumor where you have malignant stroma. That's called phylloides tumor. But we'll talk about that later. For now, fibroadenoma. Okay, so I think this will be the last slide. A lot. Oh, well, maybe I don't want to show this one to you. Because it's, well, maybe I can. Okay, so this is one organ, although it's upside down. Another skin. It is the skin. So here's the skin. Then if you look in the dermis, there's this vaguely blue nodule here. It's also well circumscribed. You can just draw an arrow, draw around it. This is another benign tumor. It's called a neuroma. I don't think you need to know this one. Just a little bonus. I want to show that to you. That was a neuroma. All right. So those are the different slides that we have. So I'm